Okay, audio 2 for lecture 1. I left you on this slide at modes of sedation, talking about time of onset. I want to refer you back to, again, the slide just before this one, talking about the various characteristics of various types of sedation, inhalation, oral, meaning taking a pill orally, intramuscular, or intravenously. And please spend some time learning the characteristics of all of those. So this course, inhalation sedation. In inhalation sedation, gases are absorbed right from the lungs into the cardiovascular system and then carried to the CNS, the central nervous system. The primary gas used for sedation with inhalation sedation is nitrous oxide and oxygen. There are great benefits to inhalation sedation. It's got a rapid onset of action and peak clinical effect happens rapidly. You can titrate to the desired effect. Titration meaning you provide to that patient the amount of drug they need, just the amount they need on that day at that time. It will vary from, of course, patient to patient, but even within a single patient from day to day. You give them just the drug amount they need and no more than that. So you have a greater control over the level of sedation you can provide, be flexible during your duration of action, very rapid recovery time, and good news for many patients who are afraid of injections, no injection is required. Now, with nitrous oxide oxygen sedation, the central nervous system is slightly depressed. Patient is relaxed and comfortable. And we talk about it having relative analgesia. You know as analgesia as pain control. Nitrous oxide raises the pain threshold, so the patient is less responsive to pain, but it doesn't totally block pain sensations. Local anesthesia is still required, particularly if you're going to be doing restorative work. It does provide pretty good pain management analgesia for tissue care. So relative analgesia, not complete pain blockage, but definitely raises the pain threshold. We're going back to chapter 1 now, just a little bit on the history of nitrous oxide, discovered by Joseph Priestley. Undoubtedly, that is a test question. One other thing I want to make you aware of, at the end of each chapter of your textbook are review questions. Make sure you do review those and that you can answer those correctly before you take any of the quizzes or a final exam. Samuel Colt did street corner sideshows with nitrous oxide. And for almost 70 years, it was used as a recreational drug at social events. It was not used in a medical or dental way in any way. It was first used in a dental way by Dr. Horace Wells. In fact, a tooth extraction was the first treatment performed with nitrous oxide. Horace Wells is considered the father of anesthesia. For many years, the only kind of, and I will quote, general anesthesia was nitrous oxide. Nitrous oxide is not a general anesthesia, but it was the best that was available, certainly in the 1800s. The next gases to come along for inhalation sedation were ether and chloroform. Nitrous oxide and inhalation sedation with nitrous oxide oxygen has other names. You may hear it called laughing gas, but here I'm talking to you interchangeably with inhalation sedation, right? You inhale it. Relative analgesia, conscious sedation, those are all interchangeable names. Over 50% of general dental offices have nitrous oxide capability. The 95% of pediatric dentists have it. I'm surprised it's not 100. 22 states in the U.S. permit dental hygienists to administer nitrous oxide sedation. We passed the law here in Michigan in 2004. With the current nitrous oxide delivery systems available, current delivery systems provide at least 30% oxygen at all times. You cannot deliver 100% nitrous oxide to a patient. So the machines won't run unless you have a level of at least 30% of oxygen. Just FYI, what you're currently breathing now, air, atmospheric air, only has just about 21% oxygen. So we're going to head over to anatomy. I believe this is chapter 8 in the book. So we're going to talk about anatomy and the physiology of respiration. You need to have a little refresher on that before you get into actually how to deliver inhalation sedation. So the respiratory system from the nose to the lungs, respiratory system broken up into the upper airway and lower airway. Our respiration is controlled in the brain. The medullary center and the brainstem controls our breathing. Inspiration, inhaling, the muscles that are in charge, if you will, of inhaling would be our diaphragm and the external intercostal muscles. Expiration, exhaling, is passive, but inspiration is active, and again, it's our diaphragm and external intercostals. The upper airway starts with the nose, and of course it's the primary entrance for the gases that we'll use during inhalation sedation. For inhalation sedation to be effective, it is critical that the patient be able to breathe well through their nose. And so someone with a deviated septum, real congested nose, enlarged tonsils or adenoids, that may impact their ability to have successful inhalation sedation. After the nose, down to the pharynx, adenoids and tonsils, it's the epiglottis, you'll recall, that directs food to the esophagus and prevents food from entering the respiratory tract, entering the trachea. The lower airway, we've got the larynx, which houses the vocal cords. The opening at the adult vocal cords is the narrowest part of the adult airway, and this is also an area with not only narrow but very strong muscles around the larynx. Down to the trachea, surrounded by cartilaginous rings, and the trachea then splits into two. It splits at an anatomical location called the carina, and it splits into the right bronchus and the left bronchus. The right bronchus is shorter and it's less angled than the left bronchus. So the right bronchus obviously turning right and going to the right lung, the left bronchus turning left, going to the left lung. More angle on the left bronchus. If an object was aspirated, say a dental material, a dental object, a crown is aspirated, it is most likely to go into the right side because that angle to the right is less so. And here's an image. Here you can see the tracheal cartilages around it, that right bronchus and left bronchus. And not to be outdone, here we have a chest x-ray of a couple of crowns in a patient's right lung. So after the right and left bronchus break into bronchioles and then alveolar sacs. The alveolar sacs are made up of alveoli, and it is at the alveoli where the gas exchange occurs with our blood, with the cardiovascular system. The exchange of gas, right, from alveoli to the bloodstream, and of course from the bloodstream back to alveoli, occurs because of diffusion. You might remember the concept of diffusion where materials, gases, liquids diffuse from an area of higher concentration or higher pressure to an area of lower concentration or lower pressure. So let me walk you through this. You've begun nitrous oxide administration. Nasal hood is on the patient. They're inhaling their first amounts of nitrous oxide. The alveoli have now nitrous oxide in them. Currently, the bloodstream doesn't have any because, of course, our bloodstream wouldn't normally have nitrous oxide in it. So the nitrous oxide diffuses from the area of higher concentration, the alveoli, to an area of lower concentration of nitrous, the bloodstream. That diffusion continues until there is an equilibrium established. That nitrous oxide, of course, is carried up to the brain. Takes a very short time, 3 to 5 minutes before that equilibrium occurs, and the concentration of nitrous oxide in the alveoli and the concentration of nitrous oxide in the bloodstream is achieved. Again, very rapid onset of clinical action. Just again, a little bit more about the physiology. Nitrous oxide is displacing nitrogen in our circulation and in our lungs. Remember, we get a slight depression of the central nervous system with inhalation sedation. One of the first signs you'll see, and you may see this on some of your classmates, is sort of a flushing of the skin, a peripheral vasodilation. Patients, your classmates, pinking up a little bit. You will know at that point, aha, we have achieved equilibrium. Some definitions: tidal flow, the automatic flow of air in and out. We normally have 12 to 15 respirations per minute. A respiration is considered one inhale and one exhale. We're going to talk about tidal volume in a bit, the amount of gas we can inhale or inspire into our lungs, and minute volume, the amount of gas brought into lungs per minute. Generally, for an adult, 6 to 7 liters per minute, less so for children. Tissues with greater blood flow receive more nitrous oxide or oxygen when it is excreted, when it is done. Nitrous oxide is excreted via the lungs unchanged. So a little bit while we'll talk about it is not excreted through the kidneys. It's not excreted through the metabolized in the liver like other drugs. It is excreted via the lungs unchanged. What does that mean? Well, there is the potential for some nitrous to be in the environmental air or ambient air, which can be an occupational hazard. Of course, we are going to talk about that. Again, I just want to, because several times I've mentioned air, ambient air, we breathe about 21% oxygen. 79% of what we're breathing is nitrogen, and it is the nitrous oxide takes the place of the nitrogen in our bloodstream. It's not taking place of oxygen in our bloodstream. I've emphasized that the onset of clinical action is rapid, and the opposite's also true. It exits the body rapidly, but it takes time for our blood oxygen saturation to recover. Decreased blood oxygen saturation can cause diffusion hypoxia. You will know your patient is suffering from diffusion hypoxia if they describe a headache or nausea or lethargy. We can prevent that. You will prevent that. You're going to administer 100% oxygen for the first 5 minutes after the termination of nitrous oxide. So this is a pulse oximeter image of one, which is measuring the oxygen saturation level. That just refers to the amount of oxygen carried by hemoglobin. Any oxygen saturation level below 90% is a matter of concern, right? It means there's a loss of oxygen to the brain. It is not necessary to use a pulse oximeter for nitrous oxide sedation.